Today we are going to learn about communication. We all know that so communication is one of the essential part in everyone's life. Also, in palliative care, this is one of the essential things in all the aspects. So, without communication, we can't live because we communication. If we do the proper communication, definitely we can able to facilitate our human relationships, connections, and among nurses and patient families. So communication is one of the basic things. And also daily basis, as nurses we are very close to the patients. We communicate lot of things to the patients and the caregivers. So we need to understand that is there any modification needed, or whether we need to correct anything. So our non-verbal communications affect the patients emotionally. That kind of things we need to understand. So today we have Miss Gayathri with us. She is a senior medical social worker. She did her MSW in medical and psychiatric from Loyola College, Trivandrum. She has been working since 2020 with us, and she has 2 years of experience, and she's working in closely working with the patients and the families and all. So she has a lot of experience. Gayatri, welcome and over to you.
Thank you so much, sister. Thank you so much for that wonderful introduction. Thank you. A very good evening, everybody. So it is indeed my pleasure to meet a wonderful group of nurses, because nurses are someone who are very close to me, and I actually love working with nurses. So because we have a wonderful group of nurses here in Pallium. So glad to meet you all. And let's move on to the session. As Sister Sheba mentioned, as you all know, communication is very essential, not only in the setting of palliative care, but everywhere. And in our everyday life, communication is very essential and plays a very crucial part in everybody's life. So let's have a look into the importance of communication, especially in the field of palliative care. So let me share the screen.
Just wait for 2 minutes. We are trying to share the screen now.
Oh, sorry, extremely sorry for that inconvenience. Sorry. So let's have a look into the objectives of today's session. So what we are going to look through is what is communication, the importance of the need of communication, some positive body languages, barriers to effective communication, steps to effective communication, And the difference between good communication and bad communication, the importance of the agent of listening, and how to advocate for palliative care. So these are the objectives which we are going to cover in today's session. So when considering the concept of palliative care, we can see that many of our patients, many of our beneficiaries come to India or any palliative care organizations with a kind of a lot of uncertainties, a lot of fear, and a lot of anguish in their mind. So our primary duty as a palliative care physician or a volunteer or a nurse or a doctor or a pharmacist, a physiotherapist, a social worker, or anybody, as a palliative care agent of palliative care, our primary duty is to clarify these issues and acknowledge the suffering. So the basic thing which we have to do is that basically we have to acknowledge their suffering. So the first thing is that we have to create a very good rapport with the patient, and we have to create a platform for the patients to ventilate their feelings so that they'll be very much confident to share their emotions. There might be a lot of dilemmas within their mind because they are facing a life limiting illness. So our primary duty is to clarify their issues and acknowledge their suffering. So patient and families with a lot of confusions come to us, and our primary duty is to clarify their issues and to create a very strong rapport between them. So the importance of communication for patients. So we can consider the scenario of patients, the physicians, or the professionals who are dealing with the patients. So the basic importance of communication in patients is helps them to express his or her needs or their concerns. So as I mentioned, they'll be coming to palliative care with a lot of confusions and with a lot of stress or trauma or whatever it is. So it will help by establishing a very strong communication. It will help the patients to ventilate their feelings and to express their concerns and their confusions. And it also allowed to permit the ventilation of their feelings. Then it also helps clarify doubt and baseless apprehensions. So when a patient comes to a palliative care center, they would definitely have some misconceptions in their mind. So if say for an example, if I'm affected with cancer lung, CA lung, uh, I might not be having very good exposure to this disease, or I might not be having very much aware about this disease. So what we can primarily do is that, when I am diagnosed with a particular disease like this, my surroundings, my friends, my colleagues, or my neighbors, or my family members, some of them, at least some of them will say that, okay, this is a life-threatening illness, or they'll have a concept that you are going to end within a month, or you are going to die soon, or something like that. So people would have a lot of misconceptions like that. And our primary duty is to clarify all these doubts. We have to give reassurance and realistic hope. A very important thing which we have to keep in our mind when we communicate with the patients who are suffering from any kind of life limiting illness is that we have to give them a realistic hope. And instead of that, we are not supposed to give false hopes to them. And give the patient and family a sense of direction. Because most of the time, the patient or the family will be having a lot of traumas or a lot of dilemmas in their mind, how to cope with this condition. What am I going to do? Who is going to take care of my family burdens? Or who is going to take care of my treatment? So people have a lot of questions in their mind like that. So what we as a professional have to do is just to clarify the issues and give a proper direction for the patient. But one thing which we have to keep in our mind is that we are not supposed to advise them, or we are not supposed to take decisions for them. Just facilitate them to take proper decision for themselves. So that is the thing which we have to do by establishing a proper communication. Then we can help them to take decisions, but we are not the decision makers. We have to facilitate a proper decision making for the patient and the families. And most of the time, especially when considering palliative in India, we see that people find it very difficult to cope with the bad news because from different departments or from different hospitals, they usually refer the patients who are in need of palliative care to us, saying that okay, just go and see a palliative care physician, or just to go and register in palliative care or in Pallium India. But they usually does not give any information about palliative care. So, and also they would not give any impression about the disease or and the seriousness of the disease to the patient. So they simply tell that go and register in a palliative care center or go and see a palliative care physician. That is the only thing they usually do. But what we have to do is that we have to help them to cope with the bad news. This would definitely be a bad news for the patient and the families. They might not be expecting this. Not only them, we all do not expect that we'll be having a severe disease, or we are going to face a very complicated disease or something like that. So we have to be very much empathetic, and we have to help them to cope with the bad news. So, dear participants, I expect this session to be more interactive because this is a session on communication which we have to practice in our daily life. So, please, if you have any queries, kindly unmute and ask me, and I want you all to be interactive. Thank you. So, let me ask you one thing. Could you all remember an incident in a hospital? Not as a professional, everybody, each and every one of us might have experiences in hospital as patients or caregivers. Usually we say not as caregivers, but as bystanders in all hospital settings. But in palliative care, especially in Pallium India, we consider equal importance to patient and the families, and we consider and we call the bystanders as caregivers. So we all might have experiences in hospitals as a patient or a caregiver. So could you all please unmute and share your experiences as a patient or a caregiver in a hospital setting? Please. Please unmute and speak. I hope my question is clear. You might have admitted in a hospital, or you might have stayed in a hospital as a bystander or a caregiver. So could you please share your experiences, either good experience or bad experience in a hospital setting? Not as a professional, but as a caregiver or a patient, as a patient. Please, come on, shoot.
Anybody?
So shall I call your names?
So either you can unmute yourself and talk, or you can put your experience in the chat box. So anybody?
Oh, that's great. Nobody is having any incident to remember in a hospital as a patient or a caregiver. That's nice.
Hi, good evening, ma'am.
Yes,
Hi,
very good.
I'm Diana. I don't have a very good English fluency, but I have some experience. 2 years before, my daughter admitted in hospital like a bedridden patient. Not in here, in Bahrain. She's stayed around 2 months in hospital. It was a very nice experience with the staff, not in our situation. With the staff, it was very good because they give very good hazard. They given very good care for me and my daughter also, because that time I am also very depressed. They given mental support and physical support. Even we didn't get Kerala food. They prescribed the Kerala food also, because some Kerala nurses, they brought their own food for my daughter and me also, for my daughter's happiness. It was very nice experience. Always I thankful for the staff, and I respect all the nurses and all the doctors because they are very nice. Thank you.
Thank you so much, Sister Diana. One thing I should tell you that is your English is very good. So thank you so much for sharing. And that is a very nice experience with Sister Diana. So see how communication plays a very major role in Sister Diana's life. So the sisters, as she told, the sisters or the staff at the hospital has given a sort of mental support for her since she was very depressed. And their communication with Sister Diana is still a rememberable one for her. So it is very important that we have to always maintain a positive a body language, positive gestures, and a very good approach with our patients and their families. So it is very important. So how as we see, we have seen that how communication is important for the patients. Like that, communication is also important for professionals. So when we establish a very good relationship with the patient and the families, our burden or our stress might decrease a lot. So establishing a good relationship is equal to less stress. So it is helpful for us to understand the patient and the impact of the illness on the quality of life of the patient and the families. Only by understanding the impact of the particular illness on the family and the patient helps us to frame a proper intervention or to set our goals. So it is very important. And understand the patient's thought process. One thing which we have to remember always is that we have to be very empathetic when we deal with patients who are facing life-limiting or life-threatening illness. And also it is important to establish a very good rapport with the caregivers also. So by establishing a very good communication or a very good relationship, we'll be able to identify the patient's thought process, and thus we can empathize more. So empathy is what? What is empathy? What is the difference between empathy and sympathy?
Good afternoon, ma'am. Empathy is we can see ourselves in same situation. Man, we are in same situation. We can sympathize them कि क्या क्या conditions होती हैं जब family में कोई बीमार होता है या किसी को कोई disease diagnose होती है तो कैसे family bear करती है. So we can empathize ourselves in same situation. So we can better understand the situation of that family.
Thank you, sister. It's perfect. It's a perfect definition for empathy. So sympathy, anybody can sympathize. Anybody can sympathize, but empathy is quite a difficult task because it is actually, the actual saying is like we are walking with other shoes. We are standing on other shoes. That is empathy. So when we stand or when we walk with other shoes, we'll get an idea that how difficult it is to walk with other shoes. So that is empathy. So by empathizing or by establishing a very good relationship with the families and the caregivers and with the patients only, we'll be able to empathize more and we'll be able to frame good interventions or good communication with the patients. And we'll be also be able to understand the patient's culture, patient's beliefs, values, concerns, and priorities. And we can also provide required information on diagnosis and prognosis. So providing a proper information on diagnosis and prognosis is very important. And as a mediator or as a professional, it will also help us to facilitate them to have a very good relationship with the management. So if considering Pallium India, majority of our patients come from below poverty line. And they are not at all affordable or they are not at all accessible to proper healthcare, even government system. So unaffordable to pay the medicines. So unaffordable to even it is very difficult for majority of patients to meet even the basic necessities. So by maintaining a very good relationship and a clear-cut rapport with the patients, we'll be able to what to say, to license for them or to be advocates for the patient and the families. So that is very important for professionals. So this is a theory which states that our words are just 7% is important to communication. So we usually believe that when we say a lot of words or when we listen more or when we what to say, to decrease our words, the volume of our words, it will be effective. But the thing is, the important thing is that only 7% of the spoken words plays very important in a communication. But 38% consists of our voice, our tone, and the important thing is our body language. You might have seen that I have been showing a lot of expression with my hands, and there might be a lot of facial expressions here. Usually I'm a person who is having a lot of expressions and my eyebrows, it is very evident. So the patient or the family members or whoever is standing in front of me, they'll get a proper idea what I am thinking inside my mind. So I am quite an expressive person. You might have understand that from this just half hour. So 55% of our body language is very important in communication. Even if we say positive words to the patient and our body language and our voice or tone is just negative, it really creates an awkward situation for the patient and even for us. So we have to be very cautious when we use the body language, gestures, voice, and tone. So let's see some positive body languages. So there are some positive body languages and negative body languages. So one of the most important area of positive body languages are eye contact. So this eye contact can be a positive body language and also can be a negative body language. Then facial expressions, it is very important to always be cautious about our facial expression. We should always have a very pleasant facial expression when we communicate with the patient and the families. Then tone of voice, body positioning, body posture, body space, touch. All these are positive body languages. And at the same time, if it is not practiced properly, it can also be turned as negative body languages. Hope you all get the content and I hope it is very clear. If you have any doubts, kindly unmute and ask in between. Okay. So this is a simple tip for making eye contact. So the one thing which we have to keep in our mind from the initial stage of communication is that from the process of registration itself, we have to be cautious about our eye contact, because people might not get an impression that she or he is staring at you. So nobody likes staring. As a professional or a patient or a caregiver, nobody likes staring. So when we keep an eye contact, we are not supposed to stare the patient or the families. So it should be very mild and very gentle. So these are some of the techniques for making eye contact. So when we talk to a patient, we have to, it is very important for a professional to focus on the triangle area of their face, like the nose, the lips, and the chin, or the eyes. So I am a person who usually looks into the mouth area of the patient when I speak. So it is more comfortable for me to focus that area, and so that I'll get a clear idea about what the patient is saying. I'll be more concentrating on the mouth part. So what we have to do is that when we communicate, we have to focus on the triangle area, nose, eyes, nose, and the lips part or the mouth part. So it should not be a staring position. We should not stare the patients. And the patient or the caregivers might be saying a lot of things, a lot of history, a lot of their story, a lot of their traumatic experiences at the hospitals or everything like that. So after hearing a lot of things, just to put an end to the conversation, what we have to do is we just have to point, or we just have to focus on any other portions of the patient face itself. or like to end that conversation, we have to shift our focus from the triangle area to any other points. It is very easy to look into the patient's head or forehead or something like that. And gradually to end the conversation, we have to, after shifting the focus from the triangle area, we have to focus on to long distance. And it is always good not to look down. If we want to look down, just after a pause, just look down slowly. Am I clear? Oh, no response at all. Am I clear? Do you have any doubts in that?
Yes, clear.
Okay, it's clear. So it is an easy trick, but it is we have to give attention to our eye contact when we communicate with patients, because we should not stare at the patients, and always remember that when you shift your attention from, or when you lose your concentration, just shift your focus from the triangle area to any other points in their face itself. And after that, you can look far away. So that is a proper way of eye contact, keeping eye contact. So next one is facial expression. So we, as I already mentioned, we always have to be very cautious about the facial expressions. So even if we say with our mouth that, okay, you are going to be all right soon, or some false hopes, if we are giving some false hopes, our facial expression should not say that, no, you are not going to get all right soon. So the words we are speaking and our facial expression should always go together. So one thing which I have to tell you is that if you are very genuine and if you're very committed and sincere with your patient, you would definitely have a positive facial expression. So saying something and showing an opposite facial expression is not at all entertaining. So we have to be cautious about our facial expression. And nowadays we use mask and all so that it is partially seen for the patient. So it is quite a relief for the professionals who are not at all good in communication, that they are not showing their complete face. So a mask is there and it is almost good for them to hide their emotions. So facial expression is very good. It is a very good body language. And one thing which we have to keep in mind is that the thing is like we have to be very genuine with our patients. When a genuine interest is there with the patients, we'll definitely have a proper facial expressions. So I hope it is clear. And our facial expression should not create an awkward situation or an awkward feeling for the patients. Try to be calm in every event and every moment, and please don't try to show your anger or your distress or your neutrality with the patients. So always be cautious about our facial expression. And if we show more interest and our facial expression says that, okay, this person is attentive and he or she understands me, there is a chance for the patient to disclose more about their personal details or their story. So always keep in mind that facial expression is very important, and we have to be very careful in our facial expressions. So next thing is smile. Smile is an important agent of communication. So even from the initial days of registration to the admission or the discharge or whatever it is, if we have a genuine interest in our patient, we should have that pleasant smile in our face. But this smile should not be in, we should not show the smile in unnecessary situations or some difficult situations. If the patient is, say for an example, if the patient is going to die or he is to his end of life situation, we are not supposed to go and laugh out. But the thing is that we always have to have a very gentle smile, a very calm smile on our face, and it will help the patients to disclose more about their details. So smile is a very good agent of communication. tone of voice, it is another important area. So rather than giving importance to what we say, the important thing is how we say that. So even if it might be a very difficult situation, or it might be a very happy situation or sad situation or a very tough situation, how we convey the things is very important. So it is not at all easy to modulate our voice. So voice modulation is very important, and tone of that voice is also important. Sinia, see, Sinia, Sinia was shocked. Oh, why I am calling like Sinia? So it was a negative gesture actually. She was doing her duty, and I was suddenly calling her Sinia. So she just got shocked. I'm sorry, Sinia. She just got shocked. Why this lady is calling me like this? So even if, say for an example, Sister Nancy Joseph, why you're smiling? Sister, why you're smiling like this? Sister Nancy, I'm asking to you, why you're smiling like this? Sister is still smiling. So see, this is just an example. Sorry, sister, this is just an example. I could see that smiling face, only one smiling face there. That's why I call you. Sorry for that. So such type of commanding voices or such type of tones should not be included in our conversation with the patients. So we can expect that patients are the ones who are facing a lot of issues. They are already here in palliative care for any kind of life-limiting illness. So our tone of voice must be very polite and very gentle. It should not create an awkward feeling for the patient and the families. Okay. Then body positioning, it is another important positive body language. So dear nurses, could you all please unmute and tell which picture shows the right body positioning? Out of these three pictures, which is the correct body positioning? First or second or third? Which was the most appropriate one in this?
I think the second one, because the doctor's at eye level and the family members also involved. The first one, the doctor's looking down on the patient. The third one, the kid doesn't look so happy.
Yeah, perfect. Perfect answer. Any other suggestions? Oh my God, Sister Nancy, are you there? Okay, she's there. She's still smiling. Okay, thank you.
Second one is also a good body positioning. Everybody is with patient. He feels like family is there to discuss the condition of the patient.
Perfect. Any other opinions? Different opinions?
Sorry, ma'am, I am unable to.
Sorry. Any other suggestions? Anybody has that opinion that third picture is appropriate? Anyone has that opinion? All correct, okay.
Yes, ma'am. Yes, ma'am. We can say ki third is good positioning.
Okay. Sister Kanchan, why do you think that third picture is also right? Do you have any reasons for that?
In this picture, the baby is sick. He is not have a feeling of hospitalization.
Okay.
The doctor or nurse, he is
Okay.
talking like as a family member. So feeling of hospitalization and the sickness is not there. Baby is very, very happy with that person.
Right. Okay, all these pictures, all these positionings are right in a way, but the second one is the most appropriate positioning, the second picture, because it gives us an impression, it gives the patient an impression that the doctor has enough time to spend with him. So he is sitting in a chair and giving due time for the patient and the caregiver. So it gives a impression that the doctor is having enough time to spend with him and he is okay to listen me. So second one is the right answer?
This is the best way for communication.
Sorry, sister, I didn't hear that. Could
Ma'am,
you?
this is the best way to communicate.
Yeah. That is the second one is the best way of communication because the doctor puts a chair and sits and he's giving enough time for the patient and the family. So that is the best position. That is the best form of communication. First one is also right because the doctor is having a gentle touch on the patient. That is also right. But it gives the impression to the patient that she does not have much time. So she has to go now. That's why she is standing and speaking. And we always have to keep in mind that when we talk with our patients or the caregivers, we have to maintain a proper eye level contact. So the patient and the professional who is communicating with them should have a same eye level. So the doctor has to sit in that position. That is the first one. Third one is also right, but it is more appropriate for that doctor if he could have sit in a chair and talk with the child. So third one is also right because it gives us an impression that the doctor and the child is having a positive relationship. The child is very happy. So that is also right. But the second picture is the best body position. I hope it is clear. If you have any other comments or opinions, you can tell me that. Okay, moving on to the next slide. So body posture, this is quite clear from the picture itself. So the first one is that the professional's body posture is not at all right, whereas the lady professional who is sitting is having a warm smile on her face, sitting straight, and she's from that picture we'll get an impression that the lady professional is ready to register the patient or she is ready to listen the patient. So that is the correct body posture, which is quite clear from the picture itself. So no more detailing on that. And leaning forward. And here also, leaning forward. When we communicate with the patient, we always have to lean forward. So in communication and in the process of counseling, leaning forward is one of the very best posture one should maintain when he or she communicates with the patient. So in counseling, we have a technique of SOLER, SOLER. SOLER is we have to maintain a square position and should have an open position. It should not be very close. The professional and the client should have an open position. Then the professional have to lean forward. So leaning forward gives an impression that the person who is sitting in front of me is interested to hear me, or he or she is giving due emphasis to my timing. So she's interested in that. That is what leaning forward shows. So it is always important to lean forward whenever possible when you communicate with the patients. It is actually a very good and very effective body language. Yes. So respecting the body space. So for a person, for everybody, there is an intimate space, personal space, social space, and public space. So there might be a lot of people who are there in the public space, but we have to have a personal space or a social space. Social space is much more wider, whereas a personal space is a little more closer. But as a professional, we always have to keep in mind that we are not supposed to enter into the intimate space of the patient unless and until he or she allows that. So we should always have a therapeutic, a professional relationship, and we are not supposed to enter into the very intimate space of the patient. So we always have to keep that in mind. So this intimate space comes in the case of touch and all. So touch is a very effective, a very effective body language. And during the touch also, we have to maintain, we have to be cautious about this personal space and intimate space. That I'll explain you later. Yes, here it is, touch. So this picture is quite a positive one, right? So, dear nurses, what do you think about the concept of touch or the positive body language called touch? What is your opinion on touch? It is very important. It is a very meaningful body language, touch. So, what is your opinion? Do you think that it is appropriate to touch the patient? Do you think it is appropriate? Come on, shoot. Yes, okay. Yes. Okay. Any no's? Any opposite answers? Any no's? Okay. Okay, then I'll ask you one question. If you understand that your touch is not so comfortable for the patient or the client who is sitting in front, how can you deal that situation? How will you deal that situation? You touches a patient, or say for an example, a patient was crying, she was keep on weeping, and she said, I have a lot of difficulties. See, now I'm also affected with cancer, pancreas cancer. So nobody is there to support me. I have two small kids. Nobody is there to take care of my treatment. My kids are going to drop out from the college and a lot of things. And she was keep on weeping like that. Then you suddenly touches her on her arm or just the palm of her hand. But you get an idea that she is not comfortable with that touch. So how will you deal that situation? Come on, shoot. These are some common scenarios, right? We can see such common scenarios in your everyday life, especially nurses like you. So come on, shoot, please. How can you handle that situation? Oh, no answer. Yeah, that shows that we care. Perfect. That is absolutely right. It shows that we care. But how can we handle the situation when the patient, when we get an idea that patient is not comfortable with our touch? Even if it is a gentle touch, they are not comfortable. Okay. Okay. I'll answer for that. So if you get an idea that the patient does not like that touch or she's not comfortable with that touch, don't take your hands suddenly off from the patient. Just keep the hands just 2 to 3 more seconds. If you touches on the palm of the patient or if you touches on the shoulder of the patient and they gives you the impression that I'm not comfortable with this touch, then you have to keep your hand there for 2 to 3 more seconds and gradually take off your hands. If you suddenly take off your hand, they'll get an idea that, oh, that was not a proper touch, or what she might have think, because my body language shows that I'm not comfortable with the touch. So what was her feeling, or does she feel so awkward? So such they'll get a lot of thoughts like that. So take your hands gradually from the area where you touch. So most appropriate places for touches the palm of the patient or the caregiver's hand, or the shoulder, or the elbow part, this part. So these are the most appropriate areas of touch. Do you have any suggestions on that? Okay, no comments. Okay. Then these are some of the core principles of communication. Respect. This is not only the core principles of communication. These are some of the very basic ethics which we have to follow, especially in a palliative care setting. We always have to respect the uniqueness of the individual. We have to respect their lives, their culture, their dignity, everything. And we always have to empathize. Then we always should give them a hope or a belief that this person is a trustworthy person. I can trust this person. He or she does not, or he or she will not disclose my details to anybody else. So confidentiality, keeping confidentiality is also very important. We are not supposed to disclose the patient's history or their story to anybody else. Okay. So the each and every case sheets or each and every patient has their own lives, their own culture, their own value, dignity, and all. So we always have to be confidential and we always have to be trustworthy. Then don't be judgmental. When we see that in the intake part itself the patient is not cooperative, or he or she is a light adamant or a light tough to handle, we should not keep in mind that, oh, this is a very bad person, oh, what an angry man, or what a bad man is this. So we should not be judgmental. Just try to accept that. No, try, you have to accept that this is why they are showing such emotions is because of their condition. They are in a very bad condition, they are in a very tough condition, difficult condition. So just admit that, just accept that, and we have to respect their privacy or their lives. So that is unconditional positive regard. So these are the core principles of communication. Then there are some barriers to communication. One is environmental barriers like lack of privacy, big furnitures in the room, noise distractions, crowded room, etc. create a lot of environmental barriers. So we had some experiences in some of our OPs in Pari, India. One or two OPs were really crowded with a lot of people, especially in Trivandrum Medical College OP and all. We have a OP there in Trivandrum Medical College every day except Sundays. So when we go there, when we just enter into the room itself, we'll be surrounded with a lot of patients who are in need of our care. So it would be a crowded room. So there is a lack of privacy, and people who are dealing with the patient and their psychosocial aspects would not get enough time to deal that in detail. So what we have done is that we just separated the rooms into two. One is for the physician and the nurses, and the other room is for social workers, so that the patients who are in need of the medicines or the doctor's advice or nurses care, they'll definitely go to that room. And the people who need to disclose more about their lives, or if they want to tell more about their story, they'll come to the next room where we ensure privacy. So privacy is very important, and without ensuring privacy, people will not disclose anything, and it definitely create a very bad feeling for the patient and the families. So that is environmental barriers. Then barriers related. So patient also has some barriers, like all the time patients might not be ready to disclose their concerns. So they have to, all the time they will not be ready to open up their details. So we have to maintain a very good rapport and have to create a platform for them to disclose or to ventilate their emotions. So some people might get a bad view that if I ask the doctor or nurse anything, what will they feel? Would they stop treating me? Or would they think that, oh, I'm a very bad person, or I'm an adamant person? So a lot of thoughts would be there. But what you have to do is that you should always create a very positive atmosphere for the patient and the families. Then lack of privacy is also an example. Sometimes people or the patients might not disclose because they respect their privacy, and if they are afraid that other people are hearing that, they will not disclose all the things. Then fear of confirming bad news, fear of treatment being denied, that I have already mentioned, fear of control over emotion. Some people might not be in a condition to disclose everything and start crying in front of others. So they will not tell anything because they fear that if I tell something about my life, I'll start crying, and I'm not at all interested to cry in front of other persons. So that is also a barrier. Then if we use some technical terms, doctors and nurses mostly use some technical terms. But if you use some technical terms, it is also a barrier for the patient to ask more about that. So we always have to keep in mind that we have to be very calm, gentle, and to make the patient more comfortable. How the professionals be as a barrier for the patient in communication. So concentrating only on physical tasks, wearing this mask, gown and all would definitely create a barrier for the patients to communicate properly. Then making judgments or assumptions is also not appropriate. Then some negative facial expressions is not so good. Then worried about being blamed or worsening the situation. If the professional do not have much information about the patient and the families, it is always good to be a good listener rather than saying some blunder things to them. So that is also a barrier, lack of knowledge. Then unfamiliar with language and dialect. If the patient comes from a different part of the country or different part of the locality, it might not be always easy for the professional to understand their language. So linguistic barrier is also one of the examples of barrier of communication. So let's see some distancing tactics. So using some distancing tactics or using some phrases or words would always distance the patient from the professional. So one is categorizing or labeling. When we say that, oh, she is a breast cancer patient, oh, she is a very difficult patient. So labeling or categorizing such things is not at all entertaining in a proper communication. So we are not supposed to categorize the patients. Then we are paying attention to the safe sides only. Like if the patient says that, doctor, I am so worried, I can't sleep properly, I also have pain in the back. If the patient says a lot of things like that and the doctor is concentrating only on the pain, it is not at all can be considered as a good communication. So the patient says, I am so worried, I can't sleep properly. Then the professional, the doctor or the nurses or whoever it is, they can ask them that, okay, why didn't you sleep last day? Do you have any mental pain or any physical pain? What is the reason for your sleeplessness? So such things can be explored rather than focusing on a safe side. Then never inquiring beyond the physical. That is quite similar to selective attention to the safer sides. Like how are you feeling? How have you been coping? So some doctors or the professionals or nurses or social workers even say that, how are you now? Okay, your pain is a little better, right? So such yes or no questions can also be avoided from a proper communication. Leading questions. So your pain is better, right? So it is just an yes or no question that should be avoided. Closed questions should also be avoided. Like, do you have pain now? So only two answers is there, yes or no. Instead of that, we have to explore more and the questions must be open-ended questions. How are you feeling now? Okay. Could you please tell me how you have been coping for the last few weeks? And how your family members are supporting you. Such things can be used instead. Then premature normalization. This is usually one thing which every professional or every human beings are doing. Don't worry, you are expected with some pain because your condition is like that. Or every patient with CA lungs or cancer it is quite expected in your situation that it is expecting. So you'll be having some pain. So such normalization should be avoided and you are not supposed to compare one patient with another. So these are some of the effective steps to communication, building a very good relationship. That is the primary thing. Then we have to open the discussion. We have to gather more information. Patient's perspective we should always have an understanding on that. Then we have to share the information. That is proper information should be shared. Then arrive at agreement on problems and plans. We should help them to arrive at certain problems and plans. Then we have to close the discussion sensitively. Rather than closing that in a very sensible way, we are not supposed to break the conversation suddenly. Okay, no problem. Just go home, take rest, and come back after 2 days. That is not proper. We have to sensibly close the discussions. So let's see a video. See that carefully, and after that, let's have a discussion on that. So I hope it is clear till this much. If you have any doubts, kindly ask. Is it clear?
Yes, ma'am.
Okay, thank you.
Mr. Arun Kumar is suffering from lung cancer.
Has to improve.
Right, very right, sister. Correct. Okay, now let's see. So, good versus poor communication, and we have some verbal do's, verbal don'ts, then non-verbal do's, non-verbal don'ts in a communication. So, let's have a look into that. Verbal do's is first what we could have do is that to greet the patient and the family. That could have been done in that video. Then we have to introduce ourselves to the patient because we are really anonymous for them, and we have to introduce ourselves. Ascertain the identity of those present. If anybody else is standing in the team, we have to introduce them also. Use open-ended questions. Encourage the patient to speak more. In that video, we have what to say. The ASHA worker has asked the ASHA worker was speaking a lot instead of helping him to speak a lot, helping the patient to speak a lot. So we have to always encourage the patients to speak. Then report important information back to the patient. Then empathetic statement could have been used. When appropriate, proper pose should be used. Then be honest about information to be given. So we should not give false hopes, and we should always be very honest about the information which we are giving. Then there are some verbal don'ts. Avoid medical jargons, which I have already mentioned. Inappropriate humor. Then avoid ending the conversation suddenly without sensibly. Avoid comparisons. Do not give premature reassurance or false hope. Then do not ask leading questions. Questions should always be very open-ended. And non-verbal do's are there that I'll show you a video in last. Eye contact, pleasant or warm facial expressions, then leaning forward, then respect the patient's need for the personal space. We are not supposed to enter into the very intimate space, as I mentioned before. Smile and touch, use it very carefully and appropriately, and we have to be very, very good listeners. Then we are not supposed to stare at the patient. Do not break into the patient's intimate zone. Then unwelcome facial expressions is not at all entertained. Then indifferent or angry tone. So voice modulation should be used, but the voice and tone must always be carefully used. So listening is also another way, a strong technique where we have to be active listeners, not passive, and explore the patient side and use more open-ended questions. So these are some of the factors helping active listening. So nodding your head, reflecting back, paraphrasing, which means that when the patient says something, in the end, we are phrasing that back to them. So which gives an impression that this person is very interested and he's listening. He was listening to me actively. So these techniques can be used in active listening. And these were some of the important components and some of the important areas of communication. And let us see the video of let us see the video of a communication. Kindly, carefully see that and identify the positive and negative things in that video.
Asha worker Raji visiting a cancer.
Ease the pain and how it improves the comfort of the patient. So this is what all I meant to communicate to you throughout the session. So I hope it is clear, and I think we have a case presentation also. So Sister Shiva, can we?
Yeah, okay. Thank you, Gayatri, for the wonderful presentation. We have only 20 minutes more, so we can go to the case presentation. Followed, we will have a discussion. Sister Sunita will be presenting a patient story. Sister Sunita, so to you.
Good evening, ma'am. Good evening, everyone. I'm Sunita Mehta from Christian Hospital, Chhatarpur, Madhya Pradesh. There is patient Mr. X, age 18 years old, male patient. His diagnosis was cerebrovascular accident and subdural hematoma, type 2 diabetes mellitus, systemic hypertension, aspiration pneumonitis, and biventricular cardiac failure. And the physical assessment was height was 170 centimeter and weight is 85 kg. That presenting complaint was Mr. X gentleman was admitted in private center outside prior menace for subdural hematoma. He was on ventilator support, and Mr. X was referred for further ventilator care and other supportive care to Christian Hospital Chhatarpur, because Christian Hospital Chhatarpur is nearby his home, so he was referred by their other hospital. And the presenting history of illness was patient was apparently asymptomatic till 10/6/2022. Patient experienced focal seizure of left upper limb since a day and developed unconsciousness, weakness of the left upper limb, and deviation of face on right side. Had history of car accident on year 2016 and fracture over the right femur bone, chest, and rib bone. Head injury was noted. History of hypertension and diabetes 2 mellitus since 20 years old. And there was surgical history, subdural burr hole surgery in 2006. On examination, patient was on tracheostomy tube, Ralph's tube, and central line Follis catheter was situated, and the bilateral pitting edema was present. Pressure sore over the sacrum and coccyx region. It's superstitious only. And the central nervous system patient was conscious, GCS wise. He was E2 with TM2. People was reactive, equally in light, and the blood pressure was 140/90 mm of Hg. Heart rate was 110 beat per minute, and the S1, S2 sound was present. Then respiratory rate is 30 minutes. Bilateral basal cryptation was present. SpO2 was 95% with 100% FiO2 in ventilator supports. Temperature is hypothermia. And the treatment and significant investigation was in the blood investigation. HB was quite low, 8 gram, and the sodium is 139. Potassium is 2.6. Dearrangement was there in electrolytes. So arterial blood gases shows like respiratory alkalosis are present, and the serum creatinine quite elevated, like 2 mg per dl, and serum calcium also 6.2, serum albumin 2.1, and chest X-ray shows bilateral lower zone infiltrated. There is psychosocial aspect, family support, emotional security, acceptance, and self-fulfillment, reduction of physical impairment. Due to reduction of physical impairment, patient develop bed sores over the sacrum and coccyx. The medication, patient receiving antibiotics, antifungals, and some diuretics. So medication peptidas 4.5 grams QHH, and injection meropenem 1 gram QHH, and antifungal is tablet voriconazole 200 mg OD, injection furosemide, loop diuretic, 20 mg BD, injection enoxaparin, isclexin 40 mg Q12H, and injection tablet digoxin 0.25 microgram, and tablet phenytoin 300 mg HSOD, tablet levetiracetam 1 gram BD, tablet pentaperazole 40 mg AMOD, tablet atrovastin 10 mg HSOD, and tablet verapamil 40 mg TID, and then nebulizer NEC 2.5 ml Q6H, and injection metronidazole 400 mg TID. Main concern was weaning of ventilator because he was referred for ventilatory support. So there is a problem in weaning from ventilator, and the prevent from hospital acquired infection. After receiving patient in hospital, he developed fever spikes, and we sent some central line tip culture. There is infection and gram-positive staphylococcus present. So preventing in hospital acquired infection is a very necessity for us, and prevent from developing new pressure sore. So after receiving patient from other hospital, we give care, and patient healed. Bed sore was also healed, and that teach the patient, teach the relative for home care. Then summary was Mr. X, 18 years male patient, admitted for ventilatory and supportive care. He was on antibiotic and calcium channel blockers and loop diuretics. Well respond to treatment. Condition was improved day by day. After 8 days of ventilator support, patient was weaned off from ventilator and introduced NIV. He stayed in 57 days under hospital supervision. Discussion point: weaning off from ventilator, the family counseling, nutritional requirement, long-term care burden. And the question is, will this patient will send home because he is on tracheostomy tube and Q2H suctioning was there, and sometime he required oxygen. So if patient relative is very poor and they don't have enough money and they have financial crisis, we cannot afford and we cannot send patient to home. But in this case, their patient relative was very rich and they are very affordable, financially strong. Though they are financially strong, they spend 5 lakh in hospital settings and they are ready to buy suction machine and O2 cylinders. But the problem is giving care, proper care. So they are asking for us to provide some home care nurses. In our hospital setting and in this place, there is no home care nurses available. So it's very difficult to relative and home patient to get proper care in the home setting. So he stay in hospital 57 days, around 58 days. After that, due to some problem, again he went to ventilator and he arrested. Then finally, it's very sad to for us to because he died this 2 September 2022.
Thank you, Sunita, for presenting this patient story. So sorry to hear that news. So, okay, anybody need any more clarification regarding the story? Please ask her. Anyway, this is the patient story. We can discuss this kind of patients we will see after this also. So we will discuss what are the things we can do for this patient and their family. So Sunita, I would like to know about his family.
Ma'am, they are financially they are very strong and they are very rich. In this area, they were very means familiar person. They belongs from very rich family, and but there is problem in emotional and care burden. So one servant is there. He was only taking care of that dada, and we were giving care full 56 days we were there, and day, night, evening shift staff only able to provide proper care. But their relative, because they are means big persons or they are very rich, so they were not taking care of Dada. He was alone inside the ICU.
Okay.
Though he was unconscious, but I saw he was crying, tear was there. So we felt very bad because he cannot speak, but he can feel some unacceptance from their family.
Okay.
Sister Sunita, can I ask you something? Who was the primary caregiver of this patient?
Ma'am, servant only primary caregiver of the patient, but only nurses are providing care in this hospital.
Anybody want to comment anything?
Regarding the family counseling, I think if the family members are not at all ready to take care of the patient, or if they are much burdened with the continuous caregiving, we can definitely refer them to family counseling, because the caregivers are the real invisible patients of each and every patient. So they are the invisible ones who definitely be striving a lot for the to take care of the patient. So definitely, family counseling is very helpful if the family members want the counseling support. We can force them, and we can't forcefully facilitate them to attend the sessions. But it is actually a very good source of support if family counseling is being done. So if they are willing for that, and if they want any relief from the continuous caregiving, or if there are any emotional burden, it could definitely be ventilated out through the family counseling. So it is helpful.
So as Gayathri said, this is very, very important, the family counseling. So at least we can tell them your presence is very, very important during the end of life care things. So that period. So that kind of things we can tell them. If they are interested, we can do the family counseling, and we can do the family meeting like that. Then they make them understand what is the current condition, and what are the things they can do for his loved ones, that their loved ones, that kind of things you can tell them. So then and also you have to listen their concerns also, what they are doing like this, why they are doing, sorry, why they are doing like this, is there any problems, you have to understand their concerns too. So then if they have any problems, we can try to solve their problems. That way we can able to with their relationships. Okay, so that things also you can do.
Yes, sister, that was a very valid point which I missed out. First thing is that we have to explore the details why they are not ready to take care of. That is very important. That was a very valid point. That is the essence. That is the proper essence of the communication. So we have to explore why they are not willing to take care of the patient. Thank you so much, sister. That was a very valid point. Thank you. So I think there are no other suggestions or comments or concerns on this.
So the last question is, will this type of patients go home? That definitely I would say yes. So we have a lot of patients with tracheostomy to wall to Foley's catheter and all. So what we do is we used to train the caregivers, primary caregivers, and make them understand how to do it. And if they are using the suction that apparatus, we will train them how to use it, and we so that kind of things we can instruct them and support them. And also if you have a home care support that particular area, then you can do the follow up through the home care, that through home care. So then if they have any doubts, they can contact us and clarify their doubts, and that kind of things you can do it. If they want to go home, you definitely, I would say yes. So our aim is to improve the quality of life and make the patient comfortable. So if they have any problem, try to reduce their problems. If you can try reduce the problems, definitely their quality of life will improve. So that is why palliative care says to the main aim is improve the quality of life of the patient and their family. And also the Gayathri ma'am said, so the caregivers problem is also nobody is listening their problems. The caregivers also is a patient, because they need to take care of all the family problem, family issues, that all things. Along with that, they need to look after the bedbound patient too. So if we usually what happen is we used to instruct the caregivers, you should do like this, you should do like that, you should. Then after 2 days, if they are not following your instructions, your attitude will change, your tone of voice will change, your facial expression will change. That all affecting the patient emotionally and the caregivers and patient emotionally. The psychosocial distress will be increased. So we should careful when we, if they are not doing properly, we have to listen. You have to ask them why you are not able to do it, that particular things. Sometimes they have a physical problems. Because of that, they cannot do the your instruction. They cannot follow your instruction clearly. So that all things you have to that listen. If you are able to listen, definitely I have a lot of experience. Even so I went few home care. I have seen few home care patients for a bed, for that bedbound patients. So that time, if I ask any after seeing that patient, I come out and ask the caregivers, so how are you? Then they are started to cry, because nobody is there to listen their problems. Nobody is listen their issues and all. So always the neighbors come and blame them, that relatives come and blame them. So that all blaming will be receiving the caregivers. No good things, good words, at least a few, that one simple good words the caregiver can't receive. So that kind of things is very, very important. If they are doing one good thing for the patients, you have to appreciate them. So they feel, okay, someone's there too, that maybe observe their things. That kind of things will be there. So always try to listen their problems. So listening is one of the valuable very valuable components of communication, listening. So always try to listen their problems. And also while we communicate, you have to remember all the non-verbal things, verbal things. The verbal, we used to use lot of non-verbal expressions than a verbal things. So lot of the non-verbal expressions will be coming out. So we have to always remember while we communicate. Okay, thank you. Any other points you want to add, Gayathri?
No, sister, you have already added everything.
Okay, then we can wind up the session. Thank you. Anybody want to add any points or any questions? And also, I would like to add one more thing. Just imagine yourself, if you have a problem, lot of problems, psychosocial issues, maybe your family issues, or your maybe your hospital issues. So lot of problems will be there. So maybe you can just imagine. So if you have a problem there, if you find someone and share your feelings, so what is the difference you will get? You got some good mental relief after you're sharing that distress with someone. So that kind of things you can think always while we communicate with the patient. Okay. Thank you.
Thank you. Thank you.
Okay. Thank you, Gayathri, for the wonderful presentation. It was a nice presentation. I hope all the points is clear to everyone. They will follow all the things while they communicate, I hope. And also, thank you, Sunita, for presenting a patient story. So short notice, she has agreed to present the patient story. Thank you once again. Thank you all for joining today and make the session very interactive. Thank you.